ça commence. Ah, Jean-Louis Vincent, oui.
Ah, ça.
Good afternoon, everybody. Thank you for the kind invitation, but I am not Jean-Louis Vincent. I can speak loudly if you want, but I'm not Jean-Louis Vincent.
Nobody's perfect.
What's up here? Escape.
Oh. Perfect, thank you. So here are my disclosure, and I have to give a talk on personalized mechanical ventilation in ARDS. So what is mechanical ventilation? We know that mechanical ventilation should be protective ventilation since a long time. And what is protective ventilation? Protective ventilation, we all know that it's a question of volume. So first step, we need to use small tidal volume. Not too small, because if you use too small tidal volume, we are going to close the lung, but not too high. And this is known since probably 20 years or more, and the well-known paper from Didier Dreyfus, probably the slide everybody have shown at least 10 or 100 for each meeting. When you use large tidal volume, you induce lung edema. So we need to use small tidal volume. When we decrease tidal volume, we decrease inflammation, both in the lung and in the systemic point of view. And the first large randomized controlled trial from Marcello Amato showed that when we use small tidal volume, we decrease mortality, even in the ARDS network. So tidal volume should be from 6 to 8 milliliters by kilogram of ideal body weight. Really important. When you take pounds, it's not the lung. So ideal body weight. The second question of protective ventilation should be pressure. So what we should do with pressure? First question, which pressure we have to look at? Everything is quite clear. We need to look at the plateau pressure, which is the most important, and it's probably the good surrogate of alveolar pressure. So plateau pressure, and it's a kind of graph for intensivists. Plateau pressure should not exceed 30 centimeters of water. And it's really important, a lot of trial this way. And if we look to the last guidelines, US guideline on ARDS, the experts said that we should use small tidal volume between 4 and 8, 6, 8, 4, 8, no more than 8, sometime probably between 4, and plateau pressure below 30 centimeters of water. This is the first important point. But to set the ventilator, we have other question. Which pressure? Plateau pressure, but we should discuss other pressure. Maybe we could talk about driving pressure. A lot of paper in driving pressure, probably a surrogate of stress and strain, but we have no recommendation on driving pressure today. We can talk about transpulmonary pressure. The paper from Daniel Telmore in Boston, 10 years old now. He has finished the new large trial, but we have no results on transpulmonary pressure. So the guidelines are 30 centimeters of water of plateau pressure. And that's everything about pressure in the guidelines. When you set ventilator, you have to set PEEP. To ask if you have to do recruitment maneuver. But I don't know, according to literature, what the level of PEEP we should use, and if we should use recruitment maneuvers. So what said the experts? The experts say that probably we should have to use higher PEEP level in severe ARDS. Don't know why, because when we look to the randomized controlled trial, they are all negative. When you compare low PEEP and high PEEP, there is no differences between one another. What about prone position? Everybody uses prone position, at least in France, and I think in Italy. Everybody used prone position after the paper from Claude Guérin from Lyon, who showed that it decreased mortality of ARDS patients when we use prone position, early prone position. But when we look to all the trials before this one, They were all negative. All these trials were negative, but we start to use prone position for all the patients. Probably because in this trial, they use an algorithm. When you increase PO2 FO2 ratio higher than 150 for 12 hours, they stop neuromuscular blockage, they stop sedation, and they wake up the patient. And when you put the patient in prone position, you increase PO2. So probably one explanation should be that when you put the patient prone, we wake up the patient earlier. And it could explain at least in part the results of this trial. But the guidelines say that we should use prone position for patients in ARDS. Strong recommendation. But when we look to the lung safe, what happened in all the world, except France and Italy, prone position is used in lower than 20% of severe ARDS. So nobody used prone position, less than a high dose of steroid or recruitment maneuver. What about recruitment maneuver? Should we use recruitment maneuver in our patient? The guidelines said we have to use recruitment maneuver, or we could use recruitment maneuver in the more severe patients. When we look to the last study, performed on recruitment maneuver, the results are confusing according to this recommendation. Because when they use recruitment maneuver and high PEEP, recruitment maneuver extended side with high PEEP according to the compliance, in really large randomized controlled trial, include more than 1,000 patients, the authors shown that when you use recruitment maneuver and high PEEP, you increase mortality of your patients. So it's quite disappointing to say that guidelines say you should use recruitment maneuver, but the results are not in the good ways. Why? The author says that maybe it's because they include the patient too late in the course of ARDS. Maybe they use too high a pressure at the recruitment maneuver with hemodynamic compromise and 4 or 5 cardiac arrest, etc., etc. But probably the answer is in the paper from Luciano Gattinoni, that when we look at CT scan, only half of ARDS patients are recruiters. So if you apply a recruitment maneuver to a patient with non-recruiter, maybe you can kill him. And that's a real serious issue with the ARDS. That mechanical ventilation for ARDS, we don't know about PEEP. We don't know about prone position. We don't know anything about recruitment maneuver. We have no efficient drug to treat ARDS. This is a slide from Caroline Calfi. For those who were not here this morning, this is a slide, and all the drugs who have been tested are negative. No efficient drug for ARDS. 2 solutions. The first is all researchers who work on ARDS don't know anything about ICU or critically ill patient. The second solution may be that we talk about ARDS and there's different ARDS. What can we do today for our patient? No PEEP, no prone position, no recruitment maneuver, maybe just giving some oxygen to our patient and back at home with the ARDS. Or saying, as the guidelines said, to tailor mechanical ventilation according to something, to personalize mechanical ventilation for our patient. Personalized mechanical ventilation according to different ARDS. This is a syndrome, this is not a disease, and maybe all the patients are not the same, and we have different patients with different ARDS. So we should not maybe apply the same treatment, the same ventilator setting for all the patients. So we have to tailor mechanical ventilation according to what? It's quite a difficult question. How to tailor mechanical ventilation? Well, in Italy, so maybe we can tailor mechanical ventilation according to pulmonary or non-pulmonary ARDS. This could be a possibility. We know that the response to PEEP is not the same for pulmonary ARDS and for extrapulmonary ARDS. This is all data. We can look at the lung morphology, or to the amount of recruitable lung. That's an old theory with the CT scan approach. We can use phenotype, as proposed by Caroline Calfi and a San Francisco team. We can use tailored mechanical ventilation according to the different phenotype, pro-inflammatory and low-inflammatory phenotype. And we know that these different patients, these different phenotype, have different mortality, but they have different responses to PEEP or to fluid administration or to inflammatory drugs, etc., etc. So maybe we can tailor mechanical ventilation according to these phenotypes of ERDS. The response to PEEP, if we look to focal and non-focal ERDS, is really different between the patient. When you increase PEEP in the focal ERDS, you increase hyperinflation. When you increase PEEP in the non-focal ERDS, you decrease alveolar collapse. The response to recruitment maneuver is always the same. If you perform recruitment maneuver to a focal patient, you are going to perform a large hyperinflation during the recruitment maneuver with hemodynamic compromise, etc., etc. So maybe it could be the good way to tailor mechanical ventilation. It's to tailor not only according to images of the lung, but according to the mechanisms of disease. Because we have to move on, and Caroline Calfee said this morning that we have to understand what happened on a biological point of view in our patient. We have to understand that. Because this is focal and non-focal ERDS patient. But what is the difference between these two patients? What is the mechanism that explains that one patient has a focal loss of aeration and the other has a diffuse loss of aeration? Probably inflammation, but not only, when we go to the PET scan. And the endotype, it means that the mechanism responsible for the phenotype is probably, we have some data, the alveolar clearance. When a patient has an alteration of the alveolar clearance, he has the diffuse ERDS. And when the alveolar clearance is not decreased in the patient, the loss of aeration is focal. We have some proof in human and in mouse that explain that the endotype is probably the alveolar clearance. So what we need to do is probably to tailor mechanical ventilation according to the alveolar clearance, according to this endotype. So what can we do to increase alveolar clearance to a patient? Maybe using some drugs, maybe increasing PEEP, or using recruitment maneuver. Because when we perform recruitment maneuver, we increase alveolar clearance. We remove lung edema from alveolar space. This is what the hypothesis of the LIVES trial. We perform a large randomized control trial on more than 400 patients with a control group, which is the ARDS network protocol, with a low PEEP and 6 ml/kg of tidal volume. And in the interventional arm, we use, for focal ERDS, we use low PEEP, high tidal volume, around 8 ml/kg, and prone position early. And for diffuse ERDS patient, we use recruitment maneuver, high PEEP, the highest PEEP for 30 centimeter water of plateau pressure, called PEEP Express, recruitment maneuver, and small tidal volume in our patient. We include more than 400 patients, 420, and 400 patients have been put in the primary analysis. All the patient was a standard patient of ICU, quite severe patient, with a SAPS-2 around 52. If we look at inclusion, the PO2 FiO2 ratio was 115 for each group, focal and non-focal, control, and interventional arm. The primary endpoint was 90-day mortality. So we include 400 patients enrolled in this trial, and unfortunately, I can't show you the results because the paper is submitted and I am not allowed to share the data with you today. But we'll have the results in 6 months or 1 year, sure. But this is the first step, this is the first trial who try to personalize mechanical ventilation according to the mechanism of disease, to the lung morphology, to the inflammation, or to something else. And we believe that it could make sense. It's this way for mechanical ventilation, but we can imagine the same thing for drugs. When we use beta-2 agonists, you know that in rats, when you give salbutamol, you increase alveolar clearance of rats. All trials performed in humans are negative. When you give salbutamol to ERDS patients, large cohorts, the results are negative. But if we perform the same study only in patients, ERDS patients, who have an impairment in alveolar clearance. Maybe it could change something. If we look at SRAGE, which is a biomarker of alveolar clearance and epithelial injury, and we only enroll in the study patients with increased SRAGE, it means low alveolar clearance, maybe the result could be different. Because when you give a drug to a patient to increase alveolar clearance, if you have no impairment in alveolar clearance, you have no benefit, but you have the adverse event of beta-2 agonists, vasoplegia, tachycardia, etc., etc. So probably we have to have a look in this way to personalize what we do. So to conclude, it is stay in time. Personalized mechanical ventilation is, I believe, important in the next step for the trials. I apologize not to be allowed to share the data with you, but one more time, personalized mechanical ventilation is just one part of personalized medicine in ERDS and in ICU for the patient. And for today, and maybe for tomorrow, the most important thing is how to phenotype patient at baseline to be sure that we give the good treatment to the good patients. I would thank you for your attention.